Thank you very much, Ahmed, and I would like to thank Professor Ahmed and all the Professor Twayer and all the organizers for the kind invitation. I apologize for the inconvenience I caused for not showing up yesterday and for being a bit late today. Also, you cannot always rely on the internet and the virtual experience as much as you rely on your physical presence. I hope that we can all meet in person very soon after we are hopefully done with this epidemic we're dealing with. Okay, without delaying further delays, as Ahmed mentioned, I'm going to talk to you today about the update of Banff classification in renal transplant pathology. Okay, let me see. Yeah. The whole target of classifications in pathology, and especially in dynamic diseases or conditions we deal with, like transplants, is that we are able to standardize our histological criteria, unify the nomenclature we use between different languages and between different specialties in medicine, and mainly between renal pathologists and nephrologists and those who deal with the transplant world, in order for us to reach a better management for the patient by understanding each other and speaking one language, which should be a standardized language. So as you know, and as you've seen these slides before, we've been working on classifications old enough, but the merit of Banff, or what's so special about it, is that it's a dynamic classification which managed to survive now for more than almost 25 years by updating itself by continuous discussions and adding evidence base. This is basically what Banff is. So it's not a single classification, it's an ongoing classification for more than 20 years now. And maybe this is why some people find Banff so perplexing or confusing, because they don't understand that it started very early on and that it's moving and that it's changing. One of the major changes in Banff is what we call work groups. Now, the Banff work groups have started since 2010, I think, and these work groups take special focus on very specialized issues, like the importance of recurrent glomerular disease, the importance of electron microscopy in diagnosing or working up renal transplant biopsies, if we need to update or do changes on T-cell mediated rejection, the evidence behind molecular diagnostics and how can we apply this to our daily routine, if we can find new surrogate endpoints for our clinical trials in transplants, and so on. These work groups present data-driven and validated refinement of the Banff criteria. So anything which is added to the Banff or which is present in the updated report of Banff actually comes from these Banff work groups. If during the meeting, which happens every couple of years, this data or this evidence was convincing, then it is updated on the report. As I said, for you, in order for you to understand Banff, you have to know that Banff has started since 1994, and that at this time we only had the concept of acute rejection. We didn't know much about antibody-mediated rejection, and we did not know a lot about chronic rejection. And through the years, Banff have managed to integrate a lot of other systems, like the CADI score, like the NIH Collaborative Clinical Trials system, and every few years, a new classification comes up. Through these years, we've changed a lot, we've learned a lot, and we've got updated a lot. And one of the major updates or the major happenings were the presence of T4D back in 2001, and the refinement of the criteria of antibody-mediated rejection, which was built on all through the years, and the emergence of what we call chronic active site of rejection, a new classification in 2007, and then several updates on this classification up till 2011. And then in 2013, we've discovered new entities. We have developed new tests like the tests of DSA. We've known that we can have antibody-mediated rejection without C4D, which is the C4D negative. This also has been incorporated within the classification. We know that we have a different type of antibody-mediated rejection which can occur late on in transplants, and this all was integrated up to 2015, and in 2017, 2019, we have refined the criteria upon which we diagnose antibody-mediated rejection and chronic active T-cell-mediated rejection, as well as integrating polyomavirus nephropathy and extramolecular studies into the new update. So this is the story of Banff. So if anybody wants to read the classification or learn about the classification, you actually need to go back at least to 2007 and build up from there in order for the report and the literature, the most recent literature, to make sense, because all of this is a build up on the previous reports on how the classification developed, parallel to the development of our knowledge, the development of our techniques. So this is how the classification looked like in 2009. Just to give you an idea, the classification is mainly based on diagnostic categories, on 6 diagnostic categories. And these diagnostic categories, number 1 is normal, or that you don't have any changes related to transplantation. And then you have categories 2, 3, and 4, where you have the rejection category, and these categories can coincide with each other, meaning that you can have different types of rejection together, like antibody and T-cell mediated rejection. And then you have category 5, which is interstitial fibrosis and tubular atrophy, what we call IFTA. And then we have category 6, which I'm going to show you that this category has changed into the category of polyomavirus and nephropathy. But more or less, the diagnostic categories remain the same. So according to this classification, we classify allograft rejection into 2 major mechanisms, antibody-mediated and T-cell mediated. And both of them, or each of them, is reclassified into acute, chronic active, or chronic inactive rejection. How do we classify this? We classify these diagnoses according to histology, plus or minus serology, plus or minus clinical presentation. The plus or minus here refers to the availability, not the importance. So if you don't have CSA, you have to rely more on histology and clinical presentation of the patients, plus or minus clinical presentation, because we all know that patients can also reject subclinically. This is why the best diagnosis is reached by integration of the 3 entities: histology, serology, and clinical presentation. And I want you always to remember that although we classify patients into antibody-mediated rejection and T-cell mediated rejection, actually we cannot control our immune response, and that most patients would have actually a form of mixed antibody and cellular rejection. Maybe one arm is dominant, or maybe both of them are dominant. So always remember this. It's us that we classify, that patients do not have to follow our classification. How do we get to a diagnosis histologically? How can the pathologist tell you that this is probably an antibody-mediated rejection, or that this is a T-cell mediated rejection? We utilize the classification in this because the classification adds scoring systems, and we count on the histological changes that we see in the biopsy, which reflects rejection. So we examine arteries, we examine glomeruli, we examine peritubular capillaries, and we examine tubular interstitium, tubules, and or interstitium. Rejection affects all the compartments of the kidney, and all the compartments of the kidney can be affected either by T-cell mediated and mediated rejection. So there is no differential selection in relation to anatomy. Any compartment of the kidney can reject by any form of these 2 mechanisms. Yes, some mechanism would favor one compartment than the other, but at the end of the day, anatomy actually has a little role to do in relation to the mechanism. According to Banff, and what most pathologists do, we score what we see in the glomeruli, in the interstitium, in the tubules, and in the blood vessels, and we apply these scores in order to try to classify these types of rejection that we see into types and grades, and give you a clue about the severity. This is the example of the acute scores. So we score the extent of inflammation in the tubules, what we call a T-score. We score the extent of interstitial inflammation in the interstitium, what we call the I-score. Then the extent of inflammation in the artery, and this is what we call the V-score, and the extent of inflammation in glomeruli, and this is what we call the G-score, or what is known as transplant glomerulitis. So this is basically what these letters, what these small letters mean in Banff. And then we do the same thing for the same compartments, but we score the chronic changes. And so we have the CT score for tubular atrophy, the CI score for interstitial fibrosis, the CV score for fibroenzymal thickening of the blood vessels, and the CG score for the glomerular basement membrane duplication, not for glomerular sclerosis. So the CG score only is related to glomerular basement membrane changes and has no relation to glomerular sclerosis. We also score additional findings in the transplant. We score the tubular inflammation, peritubular capillaritis, and we score the interstitial inflammation in relation to fibrosis. We give this one a different score, which I'm going to come to, and we also score arteriolar polynosis. Now, in 2019, the Banff 2019 kidney meeting reports have introduced updates on and clarification of criteria for both the T-cell and antibody-mediated rejection. Okay, now this is the new classification, and what you see here is a copy of the classification. As you can see, this is a very long classification with so many entities, so I'll try to make it a bit simpler. So let us first look at the T-cell mediated rejection and the Banff 2019 diagnostic categories for T-cell mediated rejection. Now, T-cell mediated rejection in Banff occupies category 3 and category 4. Category 3, which is borderline or suspicious for acute T-cell mediated rejection. Then we have category 4, which is T-cell mediated rejection, which includes two main entities: acute T-cell mediated rejection, which is subclassified into grade 1, grade 2, and grade 3. And then we have chronic active T-cell mediated rejection, which is also subclassified into grade 1 and grade 2. Okay, now I want you just to remember that in relation to the histological changes of T-cell mediated rejection can affect the tubulointerstitium, the arteries, the peritubular capillaries, as well as the glomeruli. The commonest would be the affection of the tubulointerstitium, and glomerular affection will not be as common. However, tubulointerstitium and arteries are the commonly affected by T-cell mediated rejection. The Banff lesion scores assess the presence and the degree of these histopathological changes, but these are not diagnoses. So when you look at the score tells you the degree and the severity of the T-cell mediated rejection present. But this in itself is not a diagnosis, and these scores are not exclusive. These are not exclusively on the diagnostic features seen in rejection. What are the scores in the classification which are related to T-cell mediated rejection? You have the I score, which is the interstitial score, T score, which is the tubulitis score, and then the V score, which is the enzymal arthritis score.
Okay, no problem.
And then we have the chronic score, which is the CV score. This is related to T-cell mediated, and TI score plus I IFTA plus T IFTA. I want you to notice that interstitial fibrosis and tubular atrophy are not related to chronic rejection scores. We do not integrate the interstitial fibrosis and tubular atrophy we see in the biopsy in relation to chronic rejection. It's of course chronicity, and it gives you an idea about how chronic the kidney is, but this is not a rejection-related process, meaning that the presence of interstitial fibrosis and tubular atrophy does not mean that the patient does not have an acute rejection process. So what is related to rejection is the acute changes and the chronic changes only in blood vessels, or if we have inflammation in relation to the fibrosis. But just blunt fibrosis and tubular atrophy is not a rejection-related changes. And as I said, these scores are used to establish diagnoses, but they are not sufficient to reach the various Banff diagnostic categories. You need the lesion scores and additional diagnostic parameters. Other histopathological changes which are present in the biopsy, if you have access to molecular changes, you need the serology and or the clinical data which is present. So the diagnostic process is not dependent on the scores only, it's an integration of the whole thing. The scores we see, the other histopathological changes we see, whether we have interstitial edema, whether we have nuclear inclusions, do we have interstitial hemorrhage, whatever, the serology of the patient, as well as the clinical presentation of the patient. Till 2019, we retained the same criteria or the same grades for acute active T-cell mediated rejection, which is grade 1A and grade 1B for the tubulointerstitium, and these are grades related to severity. We still have grade 2A and B, which is the entemal arthritis, which is the inflammation in the arteries or the V score, and grade 3, which is transmural inflammation or marked entemal arthritis, plus or minus fibrinoid necrosis. In relation to the arteries or the T-cell mediated rejection, which affects the arteries, the A and B depends on the number or the extent of inflammation that we see within a single artery or more than one artery. This is why we always say that it's very important to sample arteries in the biopsy and to sample more than one artery, because these lesions tend to be quite focal. So if you have a single artery, your patient can also still have a V lesion and it could be missed. What about borderline rejection? Now, borderline rejection has been introduced early on since the very early Banff classification and always remains as the most controversial category in relation to interpretation of transplant biopsies, and also for nephrologists, which also ask the question of, so you tell me this patient is borderline rejection, what am I going to do with this? Now, the term borderline rejection means suspicious for acute T-cell mediated rejection. It could be because the biopsy is inadequate. It could be because you already gave anti-rejection treatment before the biopsy, so you masked the full component or the full acute flare of the rejection process. So we cannot upgrade the rejection process to a full rejection process. It could be that the patient had a rejection and already the biopsy was delayed and the patient is resolving, or it could be that the patient is starting a rejection process and this is just what we were able to see in the biopsy. So all of these are options where you're going to get a category of borderline rejection. Bottom line is that you do have a rejection and that you do have a suspicious form of rejection. How to manage these types of patients? Well, the best management would be actually is that you again integrate the serology of the patient if they don't have any form of DSA, and together with the clinical data, and then you decide whether you want to maximize the immunosuppression of the patient, whether you want to give a mild anti-rejection treatment, whether you want to strict follow up with this patient, and if there is more clinical features which were apparent, a progressive rise of serum creatinine or anything, then you might treat, and so on. So this is a category where we are just saying that we have a high suspicion for a rejection, but we are not able really to tell you that this is a rejection due to all the causes I've just mentioned. Now, the borderline rejection was also a problem in its diagnosis, and it was very variable between pathologists. But in 2019, they have applied a different, or they have stressed on the criteria of how we should approach borderline rejection. And so any form of tubulitis with mild interstitial inflammation should be considered borderline. Or if we have only T1 tubulitis, with significant interstitial inflammation also should be considered borderline. So anyhow, without getting into too much sophisticated pathological details, this is what we mean by borderline rejection. In relation to the chronic active form of T-cell mediated, since 2017, we have subclassified this form of T-cell mediated rejection, and the criteria have been refined in 2019. And now we have a formal category, which is known as chronic active T-cell mediated rejection. And this type of rejection is classified into two grades. Grade 1 also is following the same grades in the acute form. And grade 1 mainly is related to the tubulointerstitial form. And we have 1A and 1B according to the severity of inflammation, while grade 2 is related to the changes which we see in the blood vessels, which is allograft, what we call chronic allograft arteriopathy. Let me show you. Now, this is what we mean by chronic active rejection. The term chronic active refers to when you have evidence of chronicity in the graft, but you also have evidence of activity. So this is an ongoing form of rejection, which you also need to target, because if you leave the patient without any form of anti-rejection treatment, then this patient is eventually going to lose their graft. So you see here in this picture some slightly atrophic tubules, but they also have active lesion, which is what we call tubulitis. So this on a background of interstitial fibrosis and inflammation. So this patient has typically what we call grade 1 chronic active T-cell mediated rejection. Usually these patients have, they are non-compliant or they have suboptimal immunosuppression. And this is the lesion in the artery. This is what we call transplant arteriopathy. Now, this special lesion in the arteries actually overlaps with antibody-mediated rejection. So when we see a biopsy with this feature, you can think that this patient could have a chronic active T-cell mediated rejection, which is the majority of the cases, or that this patient could have a chronic active antibody-mediated rejection. This is the lesion which follows the acute rejection of the arteries, and then you still retain the lymphocytes and you have a lot of fibrosis, as you see here. But as I mentioned, this lesion also occurs within chronic active antibody-mediated rejection. And within this scenario, it's very important to test for DSA and to see if these patients are C4D positive in order to decide whether these patients are actually rejecting antibodies or via T-cell mediated mechanism. Let's come to antibody-mediated rejection. And now antibody-mediated rejection, mainly the diagnosis of antibody-mediated rejection mainly depends on two major lines. First is the presence evidence of injury. So you need to have tissue injury in the biopsy, which could be related to antibodies, as well as clinical evidence, preferably that these patients have clinical impairment. And on the other hand, you need to establish the presence of antibodies. You need to have a strong evidence of antibodies. Now, this evidence of antibodies could be looked for in the biopsy as well as the serology. You actually need both. You cannot have only one till today. You just cannot have circulating DSA without a biopsy and then decide that your patients have antibody-mediated rejection. This is not going to work. But it can work the other way around. If you have a biopsy with microvascular inflammation and C4D positive without DSA, then C4D could be considered evidence of DSA, and then you can diagnose antibody-mediated rejection. However, if you don't have C4D and you don't have DSA, then you cannot diagnose antibody-mediated rejection. So the best way of diagnosis is to try to integrate all of these criteria together. Now, in 2019, this is the diagnostic criteria for antibody-mediated rejection. I know they are long. I'm not going to go through all the details. I'm just going to give you a general outline. As you can see, we have on the left one category, which is active antibody-mediated rejection, where all three criteria must be met for diagnosis. Then we have where these entity where we have C4D staining without evidence of criteria, and this category requires 4 features to be present for diagnosis. And then we have the chronic active antibody-mediated rejection, again with 3 different criteria. And then we have the chronic inactive antibody-mediated rejection, and this is a new diagnostic category which was not present in the previous Banff classification. So the previous Banff classifications only included the active, the C4D staining without evidence of rejection, and the chronic active ABMR, while the new one in 2019 have integrated the chronic inactive antibody-mediated rejection. And as the name implies, all what the main target was to try to tell you how active the patient is, so that you would not consider just that the patient is chronic or that the patient is active. We are trying to be more clear in diagnostic lines, which we know that is markedly needed. So a diagnosis of a chronic active ABMR implies that you have activity which you can treat or manage, while a diagnosis of a chronic inactive ABMR means that there is no further activity and that this patient is unfortunately chronic and that there is nothing more we can do. However, the reason of this chronicity or the reason why this patient is losing their graft is because of antibody-mediated rejection. Now, the scores, the diagnostic scores which are related to antibody-mediated rejection in Banff, we have the acute scores, we have the G score, the PTC score, and the C4D score. So if you remember from the previous slide, the first 3 scores were related to T-cell mediated, while these 3 scores are the ones which are related to antibody mediated. And here the chronic Banff scores as well. The CG score and the PT cell multi-layering score is also related to antibody mediated, while as I mentioned, the CV score is actually overlapping between the T-cell mediated and the antibody mediated rejection. And no further scores. Again, the bland interstitial fibrosis and tubular atrophy are scores which are not related to rejection, neither the T-cell mediated nor the antibody mediated. This is just a score to give you an idea of how much scarred the kidney is. But it doesn't mean that the patient has a chronic form of rejection. Again, these scores are used to establish a diagnosis, but are not by themselves a diagnosis, and that we still need to integrate, again, the serology, the clinical data, together with other histopathological findings in order to diagnose this patient. Now, antibody-mediated rejection mainly causes what we call a microvascular injury. And the microvascular compartments in the kidney are the glomeruli and the peritubular capillaries, and hence the importance of the G and the PT score in evaluation of antibody-mediated rejection, or the PTC score. So this is what we call the glomerulitis score, and this is the glomerular inflammation. And in glomeruli, things can progress up to a frank thrombotic microangiopathy, which is also considered a criteria for antibody-mediated rejection. By time, as this process of rejection continues to be ongoing, you see changes in the glomerular basement membrane, and this is the CG score, and you can see the glomerular basement membrane duplication, and this is what we call transplant glomerulopathy. The other side of microvascular inflammation is the peritubular capillaritis, or inflammation within peritubular capillaries. You can see a lot of neutrophils within the peritubular capillaries and lymphocytes, and this is usually correlated with the C4D positivity. And so this is what we call microvascular inflammation. Again, peritubular capillaritis. You can see here neutrophils and mononuclear cells. So peritubular capillaritis and glomerulitis, they strongly correlate with DSA. As you can see here, the more score you have of the G and the PT score, or the microvascular inflammation score, the higher incidence you have for DSA. And because of the importance of the microvascular inflammation and how much it correlates to the presence of donor-specific antibodies, we've recognized that we can have an antibody-mediated rejection without the presence of T4D, and that we can use the MVI score with a special threshold on its own in order to suggest antibody-mediated rejection. This threshold is that we have a G and a PT score more than 2. So as I mentioned, the MVI on its own is used as an evidence of the presence of antibody-mediated rejection. However, if we have a high MVI score, it's also used as an evidence of the presence of antibodies. If we have T4D, this is how T4D looks like with immunofluorescence, as you can see on the left, and on the right by immunohistochemistry. This is the positive brown staining exclusive on peritubular capillaries. Then this is also a very strong evidence of DSA, where you might not need to do DSA. And so since 2017, the Banff classification actually approves or agrees that the evidence, the presence of T4D is sufficient for the diagnosis of antibody-mediated rejection, regardless of whether we have detectable DSA or that we can detect, if we can measure the DSA or not, because sometimes we cannot detect the DSA in the patient's serum, and then you are at a loss. But if you have a T4D positive a biopsy, then this is enough to tell you that you do have antibody-mediated rejection. Again, microvascular inflammation, and as you see on the right, T4D positivity. So because of this, we recognize now that we have two types of antibody-mediated rejection. We have type 1, which is the one we see early, post-transplant, and this is the one which is related to persistent or rebound of pre-existing DSA, occurs mainly in sensitized patients. As I said, it usually develops early post-transplant. However, it can occur anytime post-transplant. Always remember this, that you can treat 1 year or 2 years post-transplant, and it usually presents with an acute decline in function. While type 2, which is associated with de novo DSA, this mostly occurs in relation to non-adherence and non-compliance. It occurs late post-transplant, but late means that as early as 3 months post-transplant, you can start to see type 2 antibody-mediated rejection, and this type presents with a slow progressive course. DSA, usually type 1 presents with class 1 and class 2, while type 2 usually is related to anti-class 2. In highly sensitized patients, there is no difference. These patients can have class 1 or class 2. In relation to C4D, remember the type 1, the one which occurs early, is mostly C4D positive. So if you don't have C4D positivity early on in an early transplant or an early biopsy, don't rush for diagnosis of antibody-mediated rejection, although except if you have a valid reason why your C4D is negative, like if you have tissue necrosis, if the biopsy is inadequate, if you gave strong anti-rejection treatment. While type 2 could easily be positive or negative. However, in highly sensitized patients, C4D is almost always positive. This is from our experience. As you can see, we have 25% prevalence of antibody-mediated rejection. This is just to show you the prevalence of the rejection type. And as you can see, the majority is actually type 2. So our patients reject much more by type 2 antibody-mediated rejection rather than type 1, which, as I said, mainly related to non-compliance. And as you can see, type 2 rejection, which was also highly associated with T-cell mediated rejection. So the presence of DSA and the non-compliance of patients will actually make patients reject with antibody-mediated rejection as well as T-cell mediated rejection. So for antibody-mediated rejection, if you have a patient with clinical impairment and you have a biopsy with suggestive tissue injury, then you need to look for antibodies. Do C4D. If it's positive, then this is enough evidence of antibodies, and you know that you have antibody-mediated rejection. If it's negative, then go back to your microvascular inflammation and see the score. If the score is significant, then in this scenario, you really need to do DSA in order to establish a diagnosis of antibody-mediated rejection. So I just want to remind you that allograft rejection can hit both compartments of the kidney, vascular compartments and tubulointerstitial compartments, and that these two compartments can be affected combined or isolated. So you can have only vascular affection, or you can have only tubulointerstitial affection, or have both, and that these both compartments can be affected by both T-cell mediated rejection and antibody mediated rejection, and that both compartments can be affected by active or chronic lesions, and both compartments can be affected early or late. This is anatomy, this is mechanism, this is type of rejection, and this is time. And so patients can present with all types of different combinations of rejection, so please always remember that. So in summary, active or acute ABMR occurs in two phenotypes, with type 2 actually usually the late type quite frequent. In ABMR, C4D positivity being highly specific through insensitive is used in the presence of NVI can substitute for DSA testing. T-cell mediated rejection remains a major problem for graft loss. Don't underestimate it. And as you see in 2019, the chronic active T-cell mediated rejection has been highly stressed. And in 2019, we also have the entity of chronic inactive rejection in a trial to stress on the fact that when we have a chronic active rejection, you need to know the element of activity in order to properly manage your patients. Finally, as I always say, remember that we don't manage our patients only to according to classifications, because classification schemes come and go. What matters at the end is morphological patterns of diseases, or what you know clinically integrate all together. Patients might not fit into a specific classification category, but that does not mean that the patient is not rejecting. Thank you for your attention.
Thank you very much, Prof Wesam. As always, a very clear and detailed explanation of the Banff. As you correctly say, it's always changing. Before I allow Dr. Kalebi to weigh in, there is a question from an anonymous attendee who asks, because as you correctly said, we must manage our patients holistically. So he asks, with our delays in biopsies, does pulsing before a biopsy significantly change the histological patterns you see? If someone is pulsed today and maybe the biopsy is done next week, will that alter what you find on the tissues?
Yes. Yes. But alerting the pathologist that you gave anti-rejection treatment will help us to integrate the findings we're seeing within the light of the fact that we know that already these patients have received a pulse steroid.
Okay. In your local data, or in any data set in Africa, do we know what is the more prevalent type of rejection? Is it T-cell or antibody mediated?
No, T-cell.
T-cell.
Antibody mediated is actually around 25%.
Okay, good. Kalebi, you want to have a word?
We have the same experience. T-cell mediated rejection is much more common. And in terms of the issue of the delayed biopsy, I think that is something that the nephrologists need to work closely with the pathologist, because the delay will probably be in terms of a final report, but you should be able to do a biopsy as soon as you can before you pulse. You can pulse after taking the biopsy and submit it to the pathologist. And usually, like we do with most of the doctors in Kenyatta, Mata, and Dr. Twahir and the rest, you can actually have a preliminary report as you're waiting for everything else to decide what you're going to do next. So I don't think the issue of delays in biopsy should be a factor, not at least in our setup where you have a number of pathologists who are giving nephropathology at the moment. Yeah.
Okay, that's quite clear. How long does the C4D staining, first of all, ever disappear in the antibody mediated rejection managed patient?
Oh, that's a tricky question. We wish we can know, but we say that yes, C4D comes and goes. Actually, that's the problem. So you need always to have this in mind. It depends. If it's really strong C4D and there is the DSAs are sky high, no, you will find it whatever you give your patient. But the weak ones, the focal ones, no, they do get affected. But they don't usually not affected by steroids. They usually affected by something stronger, like if you give ATG. If you do plasmapheresis, of course it will disappear. And if we see it in the follow-up biopsy. So if the patient is diagnosed as C4D and you manage, if the patient has C4D positivity and you manage with rituximab, for example, and plasmapheresis, or you give ATG, then the follow-up biopsy in 10 days would be C4D negative if the patient responded. But also some patients remain C4D positive as if you did not give them anything at all. So no, I can't give you a